Hello. Today we start our fourth session of the Global Oncology Implementing Science. We have today, we just speak till 6 o'clock. We introduce our uh, uh, our session today. It is very important session because it will be like introduction to the main course that will come. And the main objective of this course to implement science in favor of increased affordability of better value cancer care. In fact, it is a very big question and a very big challenge we see nowadays in the world. The more there are advance in new drugs, new technique, new devices, new technology, then it become less accessible and less affordable, and it causes many economic problems, and it needs more training and more education and many other things. Some of these new technologies and drugs and new approaches become more and more less accessible even in rich countries, and with sometimes some not well studied side effects and many other things. The solutions is not by speaking, is not by talks about global health and global oncology and cancer world and global cancer and all these things. It is very good advocate and enthusiasm and amateurs are very needed, but we, the core uh, body of our work in this global oncology university and this our win-win in our global oncology implementing science, that to how to make a big stimulus to increase via science affordability and accessibility of cancer care in the world via science, not by speaking talks, global health. Because sometimes now global health, as I see now, my brother Twalib Ngoma joined, and may he agree with me, it becomes now not the job of clinical oncology like us, or cancer care like us, or scientists, or biomedical, but become now the fashion of to speak about global health, global oncology, some speaking some talks. But what is the contribution of the main player, who are the scientists, biomedical researcher, clinicians, cancer care professionals, because they will bring they will offer the care. That is why even our work today is an introduction to our next big project that needs all of you, with global, for the first time, global clinical oncology. It is applied for many sciences globally, is applied from many specialties that at the end goes to cancer care, biology, cancer biology, medical, applied medical physics, pharmacology, pharmacokinetics, pharmacodynamic study, pharmacogenomic studies, clinical work, clinical trials, directed focus on how to access this care. Otherwise, the job of science is not complete, would not be complete. If you cannot get benefit of this care in the world, then our job is not complete. And we had, I think, many events in the world about either we have two extremes nowadays, either to speak about global cancer and global health because now is become the fashion and become good job, global health, global oncology, global, and this is funds and some talks and some tears about advanced cases and showing some advanced cases. So what? This is enough. This is shameful to show to continue to show advanced fungating cancer or these advanced cases. It is shameful to all of us, by the way. And in the same time, we have the other extreme in the other side. That is the oncology meetings, the professional of cancer, as one all, and all of us. That we are speaking about clinical trials about something which should not accessible. The job is not complete. Uh, it is not against science. It is the heart of science. It is the true science is to make it a science to facilitate our life, to facilitate the life of our human beings, and not to complicate it and to make it less more difficult, and to lose our dignity in searching for drugs or for foods or for an other requirement in life. This is the real equality. This is the real speak about disparity, and not big conferences about this is now become a favorable talk for many. But we speak about science. Now we start with the first talk is introduction. Sorry for the delay. So it's coming. It's coming. Yes. Hello. Today we present uh, uh, the first lecture of the fourth session of our global oncology implementing science. Repairing this, we are fixing this. Yes, it's coming. Entitled today this video lecture. Hello. Today we present the first lecture of the fourth session of our global oncology implementing science. Entitled today this video lecture, an introduction to implementing science, focused on increase of affordability of triple value cancer care in the real world. As I would like to say here that surely I have no disclosure of conflicts. I inspired from the work of the distinguished colleagues, international organizations, society in the world, and in committees or as advisor expert or as chair along the last 35 years. So all scientific activities are scientific activities. So no disclosure. I have no conflict of interest. First, I start with setting the notion that you all of you know it now. The win-win movement aims at the increase of affordability of better value cancer care for millions of underserved cancer patients in the world, in rich countries and low middle income countries, via scientific approaches and explorations. And win-win scenario. All will win in the real world. Welcome all to join, suggest, and to lead. Is that goal feasible? Is that realizable in the real world? Yes, via implementing science. Focus on this goal. That is why we say here implementing science. As after our win-win modification and inspired from many resources,
We present this definition of implementation science in health and cancer care. It is the scientific study of methods to promote the systemic uptake of research findings and other evidence-based practice movement into routine practice, and hence to improve the value, affordability, dissemination, and effectiveness of health services. Here is a reference for some of this definition. The scope of implementation science. Thus, not surprisingly, implementation science involves investigation at more levels than just the individual patient subject. Target of investigation may also include the provider, clinic, facility, organization, community, and even the policy environment. Here's the reference. You can visit it and read it. 5 easy steps to create your project implementation plan. 1, define your goals and milestones. 2, conduct research by intervening, surveying, and observing. Brainstorm, that's what we'll do together in panels and brainstorming discussion. Please welcome and please join and contribute. And map out potential risks. 4, assign and delegate essential tasks. 5, finalize your plan, allocate resources. Here is also a reference. You can send to me or to us, and we can send you the PDF of these slides, so you can, in order to read yourself the articles or the references or the web links to webs. There are many excellent resources about implementation science. For example, watch this video, Dissemination and Implementation Science in the Context of Global Cancer Control, Key Framework and Approaches, Gaps, and Case Studies, This is work of IARC. And here is the reference. And there is also another link to Ina's presentation, really, what's implementation science by Brian and Winners, University of North Carolina. Implementation versus implementing science. You notice that in the title of this course and this program called, we say implementing science. In fact, in addition to the literature about implementation science with many diagrams, plans, and articles, we stress on this program on the action itself. Implement science directly. As the verb implement is to bring about, to put practice into practice. Implementing refers to the process of implementing something, not to speak about implementation and presentation and about theories, about diagrams, about methods, but refer to the process of implementing something, to make it happen. So we adopted the term that refers to action implementing science in the WIN and its program. And in this program, surely. In the module 3 of this course, we see tens of scientific examples published by many authors and scientists that hopefully will, with involvement and collaboration of many, could lead to enormous increase of affordability, a better value cancer care, in triple value cancer care, and more scientific progress. All will win. It is inspired from many work. Here is some reference. Please visit these links and welcome for all discussions. There are tens of published examples by many scientists. Visit our webs, links to win-win books. As we see always, the win-win initiative and this program, Global Oncology Implementing Science, belong to all. We look forward to your feedback and scientific suggestions. Thank you for your attention. Warmest regard, warmest welcome to all. Please send us your suggestion, feedback to us, and if you like to receive as I said, the PDF of this slide, please send to us. Thank you very much, and looking forward to hear from you all. We are part.
In this video, I want to address the enormous challenges in access to cancer services globally through implementation research. This is a Global Health Catalyst initiative. In the Global Health Initiative, the Win-Win Initiative has noted with great concern that in spite of a lot of effort put in clinical research, there is no guarantee of uptake of available evidence into routine usage by policymakers. Why is this? This is the reason I am sharing this video with you. I will give an introduction on the enormous challenges in access to health services, define clinical innovations, why there is low uptake of evidence-based clinical innovations, and talk about deliberate scientific approaches using capacity building and training opportunities in implementation science research to promote uptake of research findings. As all of you are aware, in the world we live in today, we are facing enormous challenges in access to health services in general and cancer services in particular. We are all aware that there is rampant poverty, social instability, climate change effects, widening gap in health, leading to regional disparities in access to services, with access to cancer services. And at times one thinks that access to cancer services depends on geographical location where one is born. This should not be the case, and efforts need to be made so that access to services is available to everybody in spite of where they were born. If we look very carefully, there has been a lot of evidence-based solutions which have not been taken up. Why is that? The first example is the example of scurvy. The British Army noted that soldiers had skin conditions, and way back in 1601, the first randomized clinical trial of citrus to treat scurvy was conducted in 1747. That's more than 300 years ago. Yet, the British Navy did not adopt routine use of citrus to prevent scurvy until 1795. Why is there this lag between evidence and widespread usage of the evidence that has been collected? Analysis demonstrate that while the strength of evidence contributes to adoption of some clinical innovations, but not all, there must be an explanation of non-adoption of those evidence-based clinical innovations. The problem of non-uptake of effective clinical innovations will always be there unless concerted efforts are taken beyond simply the clinical innovation itself. This could include also contextual factors and involvement of non-research clinical staff. We're going to have a course designed to serve as an introduction to the principles, concepts, and methods of implementation science, because we think with implementation science, barriers to uptake of clinical innovation, evidence-based findings will be addressed, and This will increase uptake and therefore public health impact of clinical research. During the course, we will learn more about implementation science. But for today, I want to share with you what implementation science is all about. Implementation science is a relatively new field of research which has been developed to enhance the uptake of evidence-based practices and thereby increase their public health impact. In other words, implementation science is the scientific study of methods to promote uptake research findings and other evidence-based practices into routine practice. The goal of implementation science research is to identify the factors, whether they are facilitators or barriers, that affect the uptake of research findings into routine use. This shares many characteristics and the rigorous approach of clinical research. However, it is distinct in that it attends to factors in addition to the effectiveness of clinical innovation itself. It identifies and addresses barriers and facilitates tasks. So, implementation science is not being done to establish the health impact of a clinical innovation, but rather it's done to identify the factors that affect its uptake into routine use. It seeks to continue the job of biomedical research. It has a lot of challenges though, and the challenges that implementation research scientists face are: one, to integrate the science methodologies into clinical trial designs. Two, in the development of efficient methodologies of data collection with minimal disruption of the processes under study in both descriptive studies and controlled trials. There is a challenge there. Another challenge is testing and validating the theories that underlie implementation to enhance the development of next generation analytic methods and interventions. The workforce that is available now may not have the skills to do implementation science. So we need to develop implementation science workforce which has diverse and complementary skills and provide sustainable academic careers for them. I hope that after the implementation science course, given the central role of context in implementation science, implementation researchers who are doing research will try to include not just clinicians and clinical scientists, but also social scientists, economists, systems engineers, and also people who make decisions about uptake of evidence-based research findings. These are the operational partners. So there has to be some relationship between implementation researchers and their operational partners, like administrators and staff who run and staff who organize the clinics. You see, unlike clinical research, in which individuals and structures play a primary permissive or passive supportive role, in implementation science, the operational colleagues need to be full partners. This is the main difference. This is what we should learn, that there are scientists doing the research and there are operational partners who should be involved from the very beginning of the research so that this can facilitate the uptake of the evidence gathered by the research. It is in doing so that whatever resources are used to conduct the research, and when we get good findings, then the dollars used to conduct the research will have been properly used, and there will be a good return on that investment. It is crucial that whenever we gather any evidence, we also look into the fact that its uptake is not going to be automatic, and the non-uptake factors should be looked into so that it doesn't remain in the libraries only. In conclusion, the enormous challenges in access to cancer services globally could be solved through implementation research. And because of this, we thought it is important to build capacity and training opportunities in implementation science research. This could be the drivers for solving this enormous challenge. Thank you very much for listening.
Yes, I have the pleasure to introduce Dr. James Alaro, who is Program Director of National Cancer Institute for Global Health. Welcome, Dr. James. Thank you.
Good afternoon, everyone. Thank you very much for inviting us to this event today. It's really a great event to bring people of different backgrounds to talk about one issue, and that is the issue around cancer in low and middle income countries. And also to Will, thank you for giving me the arduous task of keeping people awake at 3 p.m. in the evening. So I hope I manage that as well. So I come from NCI, and I guess if one message for us to leave here with today is that NCI is a partner in combating the burden of cancer worldwide. I'll give you a little bit of an overview of the Center for Global Health. I'll mention a few priorities that we have and opportunities therein, and also emphasize the idea around global research training with a few key lessons that we've learned. So the U.S. National Cancer Institute is the nation's leading federal agency for cancer research and training. We have several divisions and offices at NCI, and we are located in Maryland, in Bethesda, where our main campus is. So our primary job is to conduct research. We support and conduct research. A very small portion of that research is done within the NCI campus, But majority of the research is actually funding outside, funding NCI designated cancer centers, funding researchers in US institutions and institutions abroad to conduct science. We believe very strongly that to do good research, you have to train the next generation. So a lot of investment really goes into that. So over 90% of our budget goes outside NCI. Our scope of work is broad, all the way from basic science going through to survivorship. And I guess most of this can be found online. And the Center for Global Health, our mission was to advance, we were established in 2010 or 2011 to advance NCI's mission to reduce burden of cancer globally. We do part of our work by supporting and facilitating global cancer research in the US and abroad. We do that by building partnerships or collaborations, as we call them, for global cancer research, and then support training for the future generation that can do that work. If somebody is looking for a job, we are looking for a director for the center, and the announcement is out there. I think it's probably due sometimes towards early June, I think it is. So all these brains here, we invite you to apply. I hope you become my boss. People before me have made a case why we do global cancer research. I will not delve too much into this, but the idea that doing cancer outside of the US really will bring different types of knowledge for the new cancers that we don't have here, and also the existing cancers, some of which present completely differently. I had a colleague yesterday, we were talking about colorectal cancer. He trained in the US, and the kind of cancers that he saw here in the US, he goes back to Nigeria, and what he sees out there is completely different from what he was taught in class. So he had to adapt his thought and bring this to the literature. There was somebody from Lancet of Oncology here today. There's really some interesting stuff happening on the ground that we hope can be brought into the fore to really inform cancer and to inform the breakthroughs that we have. Our general aim here is to improve health for all. We recognize the need for effective collaboration. We recognize that it is key to achieving this goal. Cancer will be solved because of the science. And if the science is good, whatever that science is, it doesn't matter, it will help everybody else. I put this up to just give you an example of our footprint. So NCI supports a lot of work. Center for Global Health supports a lot of work. I'll give you an example of Africa, but beyond Africa, in other low and middle income countries, currently you can see we have over 129 awards, 9 of which are awarded directly to institutions in Africa. You can see the blueprint there, which countries we are in. So we are out there, we are doing great work, and most of this work is done through collaboration. Again, this figure here is meant to just show you the breadth of our work. It goes all the way from the basic biology to cancer control. We deal with several cancers in this region, cervical cancer, breast cancer, amongst others. So it's really, really broad work, again, done in collaboration. So for this, like I said, there's a lot of work that we do, but I'll mention a few examples that demonstrate some areas where I think are our priorities and where I also think therein lies opportunities for us to exploit. So affordable cancer technologies, we know that prevention, early detection, and prompt treatment will be key to success in controlling cancer. We know that there are many technologies out there that are currently in use for the cancers that we know how to deal with, but most of these technologies were really not made for use in low resource settings. Again, the good news here is that there's really rapid development in this technology area that I think would eventually, if harnessed well, contribute to the control of cancer broadly. I'll give you an example here of work that is being done in Brazil, for example, where we have a high-resolution microendoscope that is attached to a computer form that analyzes that data in real time. They've been able to put all this in a van so that this van goes from community to community, dealing with cancer in real time. So somebody comes in, you're treated in the same visit, they see what is happening with you for cervical cancer, you're referred for treatment, and that is happening. We have several other tools. For example, we have an example of cryopen or cryopop that are being used to address cervical cancer, to just mention a few things that we are supporting. The idea here is you get this thing that is very portable, is very easy to use, so you can train. You don't need an oncologist really to be in the field to use it. You can train several people to be able to do that, and it gives you results in these settings as they are. What makes this kind of programs work is the idea that once you define a good scope, so first of all, the cancer, there are things to do about it. We know the things that we can do about it. Those cancers are preventable, treatable. You've considered the local settings under which you're working, and you're looking at the existing or emerging technologies and adopting those to be appropriate for the areas under which you work. So considering the economies of these areas, the cultures of these areas, I think is very important. But it's about people. If you create the right teams, bringing people together, we don't have to work in silos. In this case, we have engineers working together with oncologists, working together with the business partners to really come with those technologies. Making a case for everybody why getting involved is important, attracts them towards this kind of programs. The other example I wanted to give here bilateral co-funded research programs where NCI goes into partnership with other nations or other institutions in other nations. I'll give an example here, for example, US and China, where NCI partnered with China, or US and South Africa, where NCI partnered with South Africa towards doing cancer research. Again, the key here was the area of mutual interest. Once everybody agrees what is important, then you can find a way of working together towards solving that problem, making a case, each person making a case for their own needs or for their own involvement in engagement in that project. What is key here, and I think this goes to previous speakers, was that, for example, in the case of US South Africa actually brought money onto the table. And that money goes into funding the partner that is coming from the South Africa side. NCI brings money onto the table, and their money goes into funding the US PI. So these two people, with their own sets of funding, come together to work towards a common goal, and it has really worked well. Secondary to goals for this program is, for example, to help strengthen the research grantsmanship in these institutions, where NCI has really played a big role in helping South Africa bring up their own research and strengthen their own research cultures locally. So one of the big areas, and I think probably a case easier made, is around cancer health disparities. So this is where it is true that global is really local. So for example, here in the US, you get immigrant populations, you get minorities, you get underserved populations. That is true that the outcomes for cancers are different for those populations here. Nearly everybody in the US has come from somewhere. And you would think that should we have an opportunity of supporting these large comparative studies that are looking at different aspects that are informing or are telling us what are really leading into these health disparity issues that we are seeing, perhaps we can get the answers to these questions. Is it an issue of genetics? Is it issues beyond just access or failure to access care? What is it about those cultures that inform? For example, if you know that you have an immigrant population of, say, Kenyans in Boston, and they have this high incidence of cancer, perhaps going back to Kenya to look at what informs that cancer in Kenya will help you address now the population that you have here in the US. I think those would be really key, and it's easier for us from an institutional point of view to justify it to the people who give us the money, who is a US taxpayer, why it is important to do research outside of the US. Another important aspect, and I think an opportunity, is around implementation science. And again, this is a new field of research. Some people are aware of it, some people are not aware. But this is where we are asking for people to really look deeply into the economic aspects of the research that we do, cost effectiveness, look at system dynamics, simulation modeling, and all that. We are asking questions about how the idea that something is good, that you have a treatment for something, doesn't necessarily mean that it will be adopted or it will be implemented in the right way to actually give you the results that, that you seek. Where I see a big opportunity here, especially for those who are doing research, is these governments, the African governments, they are, for example, are implementing things. You can look at cancer screening, for example, cervical cancer screening. They are doing it. There are these guidelines that come out that we are really putting into force. And some of the times, these are not informed by the existing evidence, or that evidence is really not translated to suit the environment into which they are adapting it. So you can see where a partnership where scientists come and work with these governments together as they are implementing these programs, do implementation research along the way to be able to inform their work is useful. I think there's a saying about people doing the same thing over and over again and expecting different results. What are those people called? If somebody knows? Oh, I didn't say it. So, but I guess there's an opportunity here where, again, scientists can really play a big role in informing how we use what we already know that we can use to help us around cancer. One of the big focus around the Center for Global Health is training the workforce to be able to do this work. And most of the times when you talk about training, is usually about training people from the low and middle income countries. But I think there's even a bigger aspect about training people or training scientists who are in the US to be able to actually do global cancer research. So we divide our work into those two. We actually try to empower institutions here in the US to be able to conduct global research, and at the same time, train people in the low and middle income countries, empower institutions in the low and middle income countries to be able to produce this trained researchers that are able to then collaborate if you want to collaborate with somebody. If you have somebody who is well trained, I think that is a huge space. And this is one of those areas that I think the diaspora, especially those who are trained in the US, can play a very key role. Training in general, for example, you look at mentorship. We are looking at this in a different way now. So most of the times we've asked people to mentor, or we request people to mentor, but it's not formalized, or we're asking you to mentor out of the goodness of your hearts, and that can only last so long. So how do we institutionalize mentorship? How do we help people from low and middle income countries, senior professors who have succeeded, to really build in the idea of mentoring younger generation that can then come and probably replace them in the future? So we are looking into new ways and into new partnerships to do that effectively. So some of the training programs that we have, the one that I really want to emphasize about is this small mentored research grants. So we have probably about 50,000 US dollar grant programs where we give for younger people to do between 1 to 2 year type programs. This kind of money in a low resource setting really goes a long way into doing good science. And you've seen from the previous conversation here where it has been emphasized how that is useful. How do you make this program sustainable? We have sought partnerships. We are exploring new partnerships. There's one around now that is going on between Takeda, which is a pharmaceutical, Harvard, which is a cancer center here, Dana-Farber, and Aortic AACR to come together to see how together they can really make these programs flourish in low and middle income countries. Again, you do not have to always travel people to the US for this training. There's a model of training, technology-enabled collaborative training, where we are using or exploring the Project ECHO to do training where people stay where they are, bring people together to exchange knowledge, and it is working. I saw an example here that was said earlier where you use technology to really advance training. So finally, to just get this done, I think there's several lessons, and we've heard of them today. One of the ones that really speak to collaboration is the idea of doing research that is mutually beneficial to both parties, and the idea of having equity in that collaboration. And I think it is very, very important to really bring people from low and middle income countries onto the table very early on. Most of the things we are doing or we are trying to implement, for example, in most of these low resource settings are things that are developed elsewhere, and then we go bring them in here, and nobody knows what to do with them, or they are not accepted, and we are blaming people from those areas. So the idea that bring these people onto the table earlier on, I think would be useful. Then leverage existing resources, and in this case, I'm talking, for example, about the HIV platform that has really done very well in Africa. If we can use that platform to really build onto the research capacity, that would be really good. Remember that it takes long-term approach to really build effective collaboration, effective research culture in this institution. So be patient, set realistic goals and realistic measures of those success. Otherwise, if you put $50,000 down and you expect to finish all cancer problems in the world within a year, probably that will not be as successful. You might be disappointed. Thank you very much.
Hello. Uh, I see among us today Professor, some of our directors, Professor Bashkim Zebri from North Macedonia, Professor Twalib Ngoma from Tanzania. And I'm glad also to see all your names and your contributions of all of you. I am glad also to see Professor Christina Stefan, who is one of the renowned professors in pediatric oncology, and she is the past president of aortic and many other activities in the global oncology in the world. And I asked Stefan to be one of our ambassadors and one to take her role in the leadership of this movement. All of you, please, it's not the number of the participants of today or last session or next session or the people who communicate with us to receive. There are tens of people or maybe sometimes hundreds, but all of you are ambassadors. All of you are leaders. All of you, please be advocate of the message of this program to increase affordability of better value cancer care in the world via science. Please also, if you like to get my slides, because there is not because not it is not my slide, but because there are some reference to some links to some chapters in books, to some presentation, to some articles that can be preparation for the upcoming some of the upcoming hot sessions. that would be applied oncology, applied medical physics, applied radiobiomaterials, pharmacokinetic, pharmacodynamic, pharmacogenomics. It's applied things, how to cancer biology, and how to be all these to be served to to via science and in the real world to increase access for millions of cancer patients, not only in low and middle income countries, but also in rich countries now. You will see, we'll see discuss together how to reduce. This is not just speaking, by science, by scientific work, by evidence based, how to reduce the cost of a new drug, for example. It is cost $100,000 in the USA. Again, $100,000. It is much more than the average income of a citizen in even in California, a rich state in the United States. And so, what is about low middle income countries? You'll see, and you will lead this message yourself by science and by evidence base. How this reduce this $100,000 to $4,000 a year. It is published. All this published, but I don't know why we miss all this. How to double or triple the double or triple, according to the country, the number of treated patients by radiotherapy by the existing present facilities. It is published by many. It's published. Is that block the way for expansion or new centers? No, it will pave the way for the hope to increase the number of facilities and technology by tens of thousands. At least it's needed like of 10,000, between 10 and 12,000 clinical oncology radiotherapy in the world. How to smart thinking and smart plans to make surgery more accessible. All this present. How to reduce many of the drugs that used even in low middle income countries, but it's expensive. How to reduce its cost by between 70 and 80% without compromising the outcome, but even to get better value cancer care and to lessen the side effects and to be more comfortable to patient, more acceptable to patient. I asked my brother Twalib Ngoma if he would like to send some comments or something. Professor Twalib Ngoma honored us today to speak, and he is one of the co-director of this course and one of the co-founders of the Win-Win Initiative, in fact. Twalib.
Do you hear me?
I hear you, yes.
Yeah. First of all, I would like to thank you, Professor Al-Zawawi, for putting together this course. Today, the introduction has gone very well. I think that the lecture given by Alaro has given the participants opportunities in that they have been told that there is a Center for Global Science in the National Cancer Institute, and that this center is willing and ready to collaborate to build the capacity in low middle income countries, and that they are looking at win-win situation in that the taxpayers in the US would also want to see whatever science is done being beneficially to both the countries where the research was done and also to the US. there is one statement he said, which I would like to repeat, that if good science is done anywhere in the world, as long as it's good science and as long as it provides the evidence that is required, it doesn't matter where it is done. And that means that if the cost of doing good science is less, say in low, middle income country, and the good science can be done there because already we have capacity to do that good science, then we'll get more out of the funds that are available. So what we are doing now to try and build capacity in research and specifically implementation science research is the good in the right step, good step in the right direction that we are beginning now. And I would like to see in future the impact of this cause being measured by the number of participants who are actually doing implementation science. I would like to request that whoever is aware of this cause should try their best to inform other people so that more and more of us are aware of the cause and benefit from the thing that we are looking forward to in the next few weeks, months. So thank you very much, Ahmed, and thank you for the participants. And I'm here to just say that I look forward to a very professionally fulfilling cause, which will have impact in the work that we do. Bye.
Thank you, my brother, Tualib. And we count on all participants to be ambassadors to reach hundreds or even thousands of colleagues in the world to be leaders of this program. Now, my dearest Professor Bashkim Zibari, who is one of the co-director of all our work, and he's from North Macedonia in Balkans, and he is renowned medical physicist and scientist in Harvard, in Germany, and many other countries. So, my brother Bashkim, could you say your comments or notes or advice?
Yeah, dear Ahmed, thank you very much. It's a pleasure being here, and thank you also for chairing the Global Oncology Implementing Science course. As you said, we are all together here with one goal, and the main goal is, in fact, to overcome the disparities, but not also in low and middle income countries, but also in the rich countries, as you mentioned, and also Tualib mentioned. This is very important for us to join the forces in order that we identify not only the common points, but also share the experiences of different countries and different approaches in terms of fighting the disease of the 21st century. As you know, I'm coming from a region in Southeast Europe, and this region has very similar problems, difficulties, issues with cancer care, cancer treatment, compared to other low and middle income countries in the region. And the different approaches that we are having and the difficulties that we are having, we are sharing those together, and we are trying to use the scientific research, let's say, advances in research in order to overcome these issues altogether. And in the region where I'm coming, in fact, we have, let's say, a huge disparity between the quality treatment, awareness, and training and courses related to completely to different fields related to the cancer care. compared to Western Europe, European countries. And there are a lot of studies that show that there is a huge disparity in this sense. Therefore, we are here all together to share our, let's say, concern, to share our problems, difficulties, and also find solutions that are, as we have seen, as I have noticed in these last years that working together with you, are really common to all of us. So, and as you said in many times, with common forces, with joint forces, we can all together increase the quality in treatment and in cancer care, in awareness. For example, only one short example. In our country, we had an awareness program for, let's say, cervical cancer, free check for women. And you know that 50% of women didn't appear to these free checks because of the prejudgments that the society has about this type of cancer and control. So there are a lot of awareness issues that we have to do. Therefore, this program is how can we really now implement the scientific findings to convince the society, the people, that to believe more in science in order that we all together win this 21st century disease. Thank you for the moment.
Thank you, my brother, Professor Peskim Zeberi, North Macedonia. And we are together, please. And we are waiting your interesting video about the about Balkan country. We are waiting for this. It's a very nice article, even in our book. Now, I have the honor to hear from a dearest friend, Professor Christina Stefan. Professor Christina Stefan doesn't need many long introduction, because if you visit the Google, if you visit anything, any search, they'll find that she is very honorable and renowned professor and dearest friend since a long time. Christina,
thank you so much, Ahmed. I think this is really a wonderful presentation. And I'm really honored to be able to address a few words to the participants. I'll be very short because I don't know if my connection is really very good. But I would really like to congratulate you and the team who really put together such an amazing program. I think this is just the beginning. And of course, our friendship goes for many, many, many years. And I remember with great pleasure, since we were talking, or since you were so passionate about the win-win initiative and really put your heart and soul. So I think it's great to see this happening. And not only that is happening, but really the impact and really the effectiveness of collaboration and really of sharing experiences, teaching, training, mentorship, because everything that we do is actually to, be able to have the next young generation who will take over from us and will, move it forward even a step further. So from my point of view, well done. I would be interested to see some original topics, some original themes, some innovation, because we are all in, as my colleagues mentioned as well, to reduce the gap, to talk about equity. And when we talk about gap or reducing the inequalities, not only, let's say, between low mid-income countries, let's say Africa and United States, but it is in between, different countries as well. So we are here to promote equity. We are really here to advance science. And I will be also interesting to hear feedback from the participants. It will be interesting perhaps to ask the participants what would they like. Some of them perhaps are in the young stage of learning oncology. Some of them perhaps are more experienced. But then again, I think it is important to learn from them what are their needs and how could we support them in reaching their aims and goals and dreams. So thank you so much. Please count on me on anything that I could do, to not only to increase the visibility and let everyone know about this course, but really being here together and sharing from our experiences and our knowledge with anybody and everybody else in the entire world. Congratulations once again.
Thank you, dearest Christina. And we are waiting your participation as not only as a participant, but distinguished faculty and distinguished leader, co-leader in this work. We are, I agree with you completely. We would like to hear from all of you. And that is why we say feedback, because the progress of this movement will depend on all of us, on you, particularly the younger generation, because they constitute, as we say always, most of the present and the whole future. So we would like to hear from you. Please send your critics, your suggestions, your idea. This is between colleagues, so no problem if some crazy idea. Many big thing is the world that we use now started as crazy idea. Nobody believe in it, but by science, by scientific research, by working together, it becomes something that we use every day. So please, your feedback and advice and critics. No, please, it is open for all of you. And please be advocacy, be advocate, be ambassador, be leader in spreading the message all over. We would like to see in the next time more numbers of participants, more number of communication, read the articles. If any colleagues from we are partners in this. If you'd like to add something, not critics, not only now, but send by emails. You have the website, 3W GOIS GOIS website. So send your critics and everything. There is feedback for any? There is any comment or chat? This change of current of electricity. Is any chat? Any question? Thank you all. And looking for your participation. Next meeting will be the same time next Wednesday, and it will be about clinical trials, about from Professor David Kerr, and also about some facts about from real world facts about how to read and how to analyze the outcome and the articles about clinical trials, and how to criticize and how to make some critical appraisal. In short, but you just start. So till next Wednesday at the same time, we are looking to receive all of you, and you are all, please, ambassadors. Bye bye all.